Medication management touches us all and requires a complete team effort. It takes all disciplines and settings being actively involved to safely use medications in a patient and family-centered approach. We all have a role to play. So as we go through things today, I really want you to keep that in mind. And also, before we really dive into things, let's set the stage for this presentation today by reviewing the 4M framework of the age-friendly health system. If you've attended previous webinars in this series, you're aware that the 4M framework includes what matters, mobility, mentation, and medication, the focus of today's event. Utilizing the 4M framework results in high-quality geriatrics healthcare. It's important that all 4 M's be delivered together reliably with every older adult encounter across the continuum. Why is that? Well, because each of the 4 M's are interconnected. Let's use medication as an example of this. Medication is connected to mentation, where medications can affect someone's mentation, and mentation can affect the ability to take medications correctly. Medications are impacted by mobility and can impact mobility. They can affect someone's balance and their gait. And what matters needs to be considered in medication regimens and when to add or remove a medication. So implementation of the medication M in an age-friendly health system includes the identification of potentially unsafe medications and identifying opportunities to deprescribe. In addition to deprescribing, there's also making sure necessary medications are properly used and adhered to. And there are also screening tools, some of which we'll discuss today, that can help with that assessment. So with that framework in mind, here are today's objectives. We'll discuss some of the impact and prevalence of polypharmacy in older adults. We'll identify high-risk medication classes that contribute to polypharmacy and adverse drug events. And we'll review available resources and tools that can aid in our deprescribing efforts. Medication management is important because potentially inappropriate medications can lead to adverse drug events, which decrease our health outcomes and can lead to unnecessary acute care utilization and costs. For example, New England Journal of Medicine study referenced on this slide estimates that 100,000 adults in the US age 65 or older have emergency hospital admissions annually resulting from adverse drug events. Almost half of those occur in the old category of adults aged 80 or greater. 2/3 of these hospitalizations were due to unintentional overdoses, and there were 4 classes of medications that were involved in 2/3 of these administrations. So 4 high priority drug classes, including diabetic agents, anticoagulants and antiplatelets, and opioids. Other studies revolving around adverse drug events have found ADEs to be the cause of 3.5 million avoidable office visits a year and over 1 million avoidable emergency department visits annually in the United States. So studies and facts and figures like these led a multidisciplinary group to create the National Action Plan for Adverse Drug Event Prevention in 2014. The National Action Plan has been the foundation for the federal government's response to adverse drug events, including their response to the opioid crisis. It uses a multi-pronged approach focusing on high impact targets and populations for ADEs that are common, clinically significant, preventable, and measurable. A major contributing factor to adverse drug events is polypharmacy, which in its simplest definition is the use of multiple medications. For practical purposes, we usually define polypharmacy as taking 5 or more medications. And this is not limited to prescription medications only. This definition should also include non-prescription over-the-counter medications and supplements. What makes older adults prone to polypharmacy? Well, there are many factors that contribute to this. One is simply what I'll call the accumulation of medications over time. When many adults hit middle age and begin to start taking medications in small doses to help with common chronic conditions like blood pressure, cholesterol control, what happens once these are started is we have a tendency that once we start a medication, even if it's effective or not, we often continue on it as long as there's not some sort of severe adverse reaction to that medication. These meds continue, and over time doses are increased and additional medications are added to either help manage that condition or others, and we just see those medications accumulate. As we age, we also end up with multiple providers as we begin to see specialists. This highlights the importance with these multiple prescribers of medication reconciliation and having up-to-date medication lists with every provider that's seen. And of course, chronic conditions have a major impact on medication load. According to the CDC, 56% of adults age 65 and older have 2 or more chronic conditions, and almost a quarter of them have 3 or more chronic conditions. These conditions often require multiple medications to manage those conditions. One example is the multiple medications needed to manage heart failure. This is also true with diabetes, hypertension, and other chronic conditions. Finally, I wanted to close this slide out by circling back a little bit to the point made earlier on this slide that once a person starts on a medication, they often continue on it, regardless of their effectiveness. This can be true for medications started as a standing order during a hospital or rehabilitation stay. A prime example of this that we'll talk about a little bit later is the use of proton pump inhibitors. Also contributing to polypharmacy is the fact that in general, prescription drug use continues to increase at a rate that is not just attributable to our aging population. We have more and more drugs available to us and more conditions to treat. I often say that just like we often hear there's an app for that on our phones, right? Where there's an app for anything that we need help with, it seems. We can also say there's a med for that when it comes to our health. And it's really easy to default to using medications as our initial response when some sort of treatment is needed. This NHANES study here on this slide showed that overall prescription drug use increased 9% from the year 2000 to 2011. And during this study, they also found that those taking 5 or more medications increased from 8% of the population to 15% of the population. And I don't have more up-to-date data on this, but I'm certain that the 2021 numbers on that, the prevalence of that is even higher than it was a decade ago. This same study showed 2 in 5 adults age 65 and older take between 5 and 9 medications, with almost 20% taking 10 or more medications. I've seen more recent studies that show that 5 to 9 prescription range could be as high as 60% now. So we have even a greater amount of individuals that are older adults that are meeting the definition of polypharmacy. Now, not all polypharmacy is bad. If medications are indicated, complementary, and beneficial, then polypharmacy is acceptable. However, when we get into medication overload, this is when we see those unnecessary medications. And there's kind of some different ways that we can categorize unnecessary medications. And these include those that are never necessary, And an example of those would be a medication that's prescribed simply just to treat the adverse drug effect of another medication. There is the example that I kind of discussed earlier too, where the medication is indicated but not beneficial. We're just continuing with the med even though we're not seeing the benefit that we intended to use it for. It's just not working, but yet we never discontinue it. We also could categorize a medication as no longer necessary. So it might have been necessary at one point in time, but is no longer necessary. Some examples here include statins in those that are older. We'll talk about that in a little bit, as well as daily proton pump inhibitor use. And there's a final category that we can look at with polypharmacy where, again, these might be unnecessary medications, and that's involving over-the-counter meds and supplements. Again, we don't want to bucket this just with prescription medications, but we want to include everything that's being taken. It is these unnecessary medications that lead to a medication overload and can lead to or result in a prescribing cascade that leads to an adverse drug event. There are estimates that the risk for an adverse drug event increase by 7 to 10% with each medication that's added to a regimen. So when we consider that we have 60+% of our older adults taking 5 or more medications, their odds of an adverse drug event are quite high. What is a prescribing cascade? What do I mean when I refer to that? Well, a prescribing cascade isn't as beautiful as the cascade in this artwork on this slide, but it can be just as dangerous. Those are definitely some rapids there that have some danger to it, and so can a prescribing cascade. The definition of a prescribing cascade is using another medication not to treat a medical condition, but rather to treat the side effects of another medication. And a little bit way of viewing it here is on this slide, where a medication causes an adverse drug event, which then either is misidentified as an illness, which results in another medication being prescribed, which then leads to potentially a drug interaction with that original medication, or another adverse drug event, which then gets us in this cycle again, where we are prescribing just to treat medication side effects. The cascade begins when, instead of changing the medication causing the adverse event, so instead of treating it at the root, we add another medication to treat the symptoms. Again, we're avoiding that baseline cause. OTCs and supplements are also a contributor to polypharmacy. It's important to obtain a complete medication history list, including over-the-counters and supplements. It's estimated that 50% of patients do not inform their providers of all non-prescription medications, and this can lead to adverse events. An example of this is ginseng's effect on blood sugar and potential for hypoglycemia. There's also a lot of considerations with over-the-counter cough and cold products and their potential effect on hypertension, and also accumulation of acetaminophen when used in combination with other pain relievers. And there's also, that we could go through a huge list of examples with interactions with warfarin and many commonly used supplements, which then can increase our risk of bleeds or our risk of clotting, depending upon which way the supplement has an effect on the blood thinning properties of warfarin. As we age and our bodies and priorities change, so should our medication management, which is why we may look to reduce medication burden. What was appropriate treatment for someone at the age of 65 likely needs to be adjusted when they're 85. There are many reasons for this, including physiologic changes that increase our chance for adverse drug events, including decreased kidney and liver function, which change the way our bodies metabolize drugs. A smaller dose of a drug may have the same therapeutic effect as a larger dose did when we were younger. So if we did not adjust that dose and continue on our larger dose, the likelihood of an adverse drug event increases. We also have changes in our priorities. As we get older, quality may become more important than quantity. Primary prevention may no longer be a goal. The goal may shift more to reducing medication side effects. It's important to understand what matters to our patients and use that as a consideration in their medication management. There's also the opportunity to potentially reduce costs. As we know, as incomes become more fixed and the cost of medications continue to rise, sometimes medication costs become a factor, as well as overall healthcare costs. A challenge that we have in reducing medications is that our evidence-based healthcare system does not have a lot of studies and guidelines that include older adults. It's been more of a one-size-fits-all approach. Clinical drug trial participants are often not representative of an older population. However, some of our more recent treatment guidelines are beginning to take function, frailty, and autonomy status into consideration and are allowing more flexibility in targets as we age. And this change, even though it's being reflected in our guidelines, is taking a little bit longer to be adapted by our healthcare system. We're having a little bit of a hard time adjusting and realizing that our approach does need to vary. An example of this is A1C targets with diabetes are more relaxed in older adults, with the focus more on trying to avoid hypoglycemic events. So we still want to have some control, but we also need to make sure that we're avoiding those hypoglycemic effects. So the absolute lowest number may not necessarily be the best number. These targets are even more relaxed in those with multiple chronic illnesses and cognitive impairment. So again, we're starting to see some flexibility in these guidelines, but we definitely need more studies specific to older adults, and it will take a little bit of time for the health profession to adjust to that some as well. That's why we have movements such as the 4M movement. So with all of this being said, there are opportunities to deprescribe or to reduce and eliminate medications. Let's look at some high-risk medication classes that contribute to polypharmacy and adverse drug events, and thus present the opportunity for deprescribing. The first class of medications that we'll talk about are statins for reducing cholesterol and providing cardiovascular protection. With statins, we see decreasing benefit with increasing risks as we age. While effective for secondary prevention, the use of statins for primary prevention is uncertain, especially in older adults. Current guidelines from the ACC and AHA simply state that for those age 75 and older, the decision on whether or not to use a statin needs to consider clinical assessment and the overall reduction of risk in treatment. We have supporting evidence from ALLHAT study that also in a secondary analysis found no benefit for primary prevention use of statins in those over age 65. So again, it gets to that quality over quantity and that balance of risk versus benefit with statins. This next class of medications that we're going to discuss is broad and a big challenge in in geriatric care, and that is anticholinergics. Many medications have anticholinergic effects. This may be part of their actual therapeutic benefit or maybe an adverse effect. Either way, these all have risks and should all have big proceed with caution warnings associated with them, as risk versus benefit considerations need to be made. There's a wide variety of drug classes, as you can see here, that have anticholinergic effects. Antihistamines, antidepressants, antimuscarinics, antispasmodics, a wide variety of medications that have different degrees of anticholinergic effects. And the reason why anticholinergics are such a challenge and red flag is that they have a side effect profile in older adults that can quickly result in prescribing cascades. These medications can cause dry mouth and dry eyes, constipation, urinary retention, elevated heart rate, and have CNS effects, including drowsiness, confusion, delirium, and memory loss. Anticholinergics can be a source of behaviors in older adults and need to be looked at closely as a potential root cause of behaviors. So lots of potential challenges, and when we look at some of those side effects, we can see that they may be confused with other conditions and result in, again, those additional medications that are being prescribed simply to treat the side effect of the anticholinergic med. Another challenge with anticholinergics is that with urge incontinence, those medications have medications to treat urge incontinence have anticholinergic properties, which are directly at odds with the cholinergic treatments that are used for those with dementia. So again, you have those two competing against each other, and in a dementia patient, those anticholinergics can really exacerbate the individual's dementia, accelerate it, and lead to those additional behaviors as well. So in situations like these, there might be non-pharmacologic alternatives that need to be considered in these situations. Another red flag type of drug class in older adults that are benzodiazepines. The American Geriatric Society advises against using benzodiazepines in older adults, but they continue to be massively prescribed to this group of older adults that have the highest risk for serious adverse events from these medications. Benzodiazepines are prescribed to help with a variety of conditions such as anxiety, insomnia, restless legs. They're sometimes used as a muscle relaxants. However, they have serious side effects and again warrant strong consideration of risk versus benefit when starting or continuing therapy. A lot of benzodiazepines are prescribed in the primary care setting, and as we see here, up to 8% of the population, which is quite a bit when you think about it, might be prescribed a benzodiazepine. There are lots of bad things in older adults that can happen with benzodiazepines. Falls, amnesia, dementia, impaired driving, hip fractures related to those falls. Dependency is a big thing. Again, this is one of those things where once you start on something, it can be a challenge to get off of it. And so that is, and then loss of REM sleep is another factor. So even though benzodiazepines might be used to treat insomnia, again, the quality of the sleep might not be there. So when we look at a dependency in benzodiazepines, when we're trying to taper someone off of them, it's important to do gradual dose reductions and a slow taper. Some recommendations are no more than 25% decrease every couple of weeks. So depending upon the dose that someone's at, it might take some time for that to occur. We need to have discussion with patients and families to discuss the risk and benefits so that they understand what's happening with these meds. And when we do our dose reduction plans, how there could be some bumps in the road, but how we plan to manage any withdrawal symptoms, and then also discuss treatment options and alternatives outside of benzodiazepines, again, for that underlying health condition and what we can do moving forward instead of having to rely on a benzodiazepine. So now let's shift to another class of medications that are troublesome in our older adults, and these are antipsychotics, which are often used to manage behaviors. These are similar to benzodiazepines and are anticholinergics like we discussed, where these are red flag medications where our risks do often, again, outweigh the benefits. The challenge with antipsychotics is that they are used more for off-label indications rather than what they were initially approved for. This is not bad in and of itself, as many of the medications we use over time develop off-label uses. But the challenge with off-label use is that we have unintended consequences that are not identified during clinical trials, since off-label use did not have a clinical trial performed. The biggest off-label use for antipsychotics is for behavioral and psychological symptoms of dementia. However, even though they're commonly used for this, studies have demonstrated only 11% effectiveness with antipsychotics in managing dementia-related agitation. So again, what we have here is a situation where, with polypharmacy, where a medication such as an antipsychotic might be started to treat some behaviors. It's not effective, yet we never discontinue it. We just continue with that and add more on to that. So that is one of the challenges we have with antipsychotics. In addition to that, we also, to their lack of efficacy, we also see adverse effects such as increased mortality, resulting in antipsychotics having a black box warning, and a higher fall risk. Antipsychotics also can cause tardive dyskinesia, which can result in additional adverse events and further polypharmacy. So again, a lot to consider with antipsychotics. There are alternatives to these medications, and a lot of this involves having an individualized approach utilizing non-pharmacologic interventions. Identification of these root causes of the behavior is a key. Some of these examples include distracting and diverting. A good example of that is music therapy is often used to help someone that is having behaviors. There's the empirical treatment for pain. Pain is often might be an underlying cause of a behavior. If our older adults, especially those with dementia, have a harder time expressing when they're experiencing pain. And so if someone is having behaviors, giving them some Tylenol and see if that helps to resolve the behavior. There's also opportunities to go with the flow and to use positive body language. Don't try to argue with a person. You know, if they're living in 40 years ago, you need to go and try and relate to their experiences from 40 years ago. And so that goes along with not trying to rationalize with them on these things. So it's not the easiest approach, but again, that individualized approach, taking what matters into consideration, can help look for alternatives with antipsychotics. The next class of drugs that we'll talk about are proton pump inhibitors. And this is a class of potentially inappropriate medications that maybe haven't received as much attention as these drug classes that we previously discussed. The use of our little purple pills has been wide-reaching, but the long-term consequences of their use are now becoming more known, and greater attention needs to be given to their long-term use, especially in older adults. The contribution of long-term proton pump inhibitor use to polypharmacy is evident in this first bullet on this slide, where up to 70% of prescriptions for proton pump inhibitors have no actual apparent indication. And one of the things that contributes to that is that up to 50% of hospitalized patients are discharged on a proton pump inhibitor when they weren't on a proton pump inhibitor when they were admitted to the hospital. Proton pump inhibitors have value when someone is in the hospital and they're in a reclined position, and that there's some justification for that. However, when they're discharged back to their home setting, that need may not no longer be there, yet the medication continues. Long-term proton pump inhibitor use is only indicated for a handful of situations, really, including esophagitis, hypersecretion, and refractory reflux. So again, they're more designed for shorter durations and not for chronic use. And this long-term use, often for potentially acute needs, has led to some dramatic consequences, primarily resulting from the reduction in stomach acidity. There's a reason why our bodies have the pH that we do. And some of the adverse effects of not having that are an increase in C. diff infections, community-acquired pneumonia. We need acid in our bodies to absorb calcium. And so with that, we can see hip fractures as well as B12 deficiency. And PPIs also can impact our kidneys and have some connection to dementia as well. A challenge with discontinuing proton pump inhibitors is that there can be a rebound reflux in up to 10% of individuals when discontinuing the med. This, however, can be made more tolerable by gradually decreasing the dose, using the PPI when needed while doing the dose reductions, and taking non-pharmacologic approaches to reduce reflux, as well as the occasional use of an antacid as well, as long as that doesn't cause any interactions with other medications or conditions. We also have other potentially inappropriate medications to use with caution in older adults. Anticoagulants and antiplatelets need more caution as we age due to our increased risk of falls and bleeding. We have potential issues with antidepressants and mood stabilizers, and Bactrim, sulfamethoxazole, trimethoprim has the potential for hyperkalemia with ACE inhibitors and ARBs. So again, lots of consideration that needs to be done in older adults. And again, I can't stress enough the need for that risk versus benefit discussion with patients and their families. So how do we address polypharmacy? What resources are available to help us with this? Well, the first step to addressing polypharmacy is having a comprehensive medication review and looking for drugs which are either causing or at a minimum contributing to potential symptoms. This is where, again, that 4M framework is important. So there's a variety of symptoms that we can look to see whether or not they are drug related. So if someone that is on a benzodiazepine, for example, is talking about fatigue and tiredness or having falls, we need to be looking at that drug as a potential cause. Constipation and certain incontinence, we can look at our anticholinergics. There's also loss of appetite, so weight loss, potentially weight gain can be an issue as well. All of these rather standard types of symptoms that we may attribute to something else, we do need to take a look at medications as well to review for possible issues there. The first option to preventing and avoiding polypharmacy altogether is by taking a proactive approach. This can be accomplished by all items on this slide, and these are also useful to address active cases of polypharmacy. But some of these examples include having a medication list with diagnosis. That is very important, and that medication list should include over-the-counter medications and supplements as well, and that should be brought to a visit with every provider so that everyone is assured that updated medication lists are on file. There's the opportunity for what we call brown bag visits, where everyone just, you toss all your meds in a brown bag and you bring it in for us to look at. And this is a great opportunity. I've done these before in assisted living facilities, and it's amazing some of the things that are brought in, because you ask them to bring in everything they got in their medicine cabinet. And those provide some really good opportunities to address polypharmacy situations. Of course, I'm going to advocate for utilizing your pharmacist for comprehensive medication management, medication therapy management. One example of this that we have in North Dakota is utilizing OneRx, which is a screening for people receiving opioids for risk of opioid misuse and overdose. We have lots of good tools available to us, including the Beers list, which we'll talk about here a little bit more shortly. Medication reconciliation is a key when you have transitions of care occurring. It's important that we have communication with all providers for the individual, including specialists and primary care, and their pharmacy where they're receiving the medications from. A great example of how medication reconciliation can be improved is med-to-bed programs, where the medications are given to an individual before they are discharged from the hospital, so that they have their home meds on hand with them, they understand the changes that have been made, and then having that information communicated to their other providers. Also, the proper use of electronic health records can also aid with medication reconciliation. And finally, having that shared decision-making and patient engagement to understand what matters to that patient can help with alignment and avoiding polypharmacy. In addition to on this slide, I would also mention the importance of considering non-pharmacologic alternatives as well as primary options where available. Again, trying to avoid there's a med for that type of perspective. For active instances of polypharmacy, we need to look at deprescribing or the gradual dose reduction and elimination of unnecessary medications. Healthcare professionals have a reluctance to deprescribe, or at least some do, as they think patients and families may object to discontinuing chronic meds. However, a study by Reeve and others in the Journal of the American Medical Association found that 90% of patients are willing to stop a medication if it's recommended to them by their physician. So it can be done. They are open to these options, especially when presented to them in the right way. Another challenge with deprescribing is that there are not as many evidence-based practices on how to do such. There is always evidence on how to initiate treatment, but not as much around discontinuing it. Thankfully, we have more tools becoming available to assist us with this. And these tools include a variety of options for both the provider to familiarize themselves with opportunities to deprescribe and taper, as well as to the patient. So some of these tools include algorithms, pamphlets, checklists and decision aids, as well as our increasing body of research that is available around how to deprescribe and how to taper meds. And a great example of this, a great resource for this, is the website deprescribing.org. This growing website originates in Canada and has materials for both prescribers and patients to help make decisions regarding deprescribing. This includes a lot of those tools that we mentioned on the previous slide, such as algorithms, and they have algorithms to help with deprescribing proton pump inhibitors, antihyperglycemics, antipsychotics, benzodiazepines, and others. So a lot of those red flag drug classes that we talked about. Pamphlets with patient facing education are also available to help them understand the opportunities that are available, and again, some of that risk versus benefit. Another helpful tool is the website choosingwisely.org. This website, again, has clinical and patient-focused materials to facilitate conversations regarding the necessity of medications, testing, and other medical treatments. While designed to be used in conversations that happen before initiating therapy, they can also be helpful when discussing deprescribing. The Beers criteria is a standard in the United States for identifying potentially inappropriate medications. So this is another resource available to us. And no, the Beers list doesn't have anything to do with alcoholic beverages. The Beers list was started in 1991 by a geriatrician named Mark Beers. It offers evidence-based recommendations on drugs to avoid in the elderly, along with the rationale for their use or for not using them, and a grading on the quality of the evidence behind the recommendation and the strength of the recommendation. The Beers criteria should be viewed through the lens of a clinical judgment to offer safer non-pharmacologic and pharmacologic treatments. The Beers list is currently maintained and published by the American Geriatric Society, utilizing a panel of experts, and was last updated in 2019. It's the foundation for potentially inappropriate medication lists used in a wide variety of quality measures from national organizations, including CMS and NCQA and the Joint Commission. Here's an example of how potentially inappropriate medication, or PIMs, are identified in the list, their recommendations, and the rationale behind them. The American Geriatric Society, or AGS, has these materials available on their website, although they must be purchased. However, you didn't hear this from me, but if you go out and Google the Beers list of inappropriate medications, you can get access to a variety of publicly available materials highlighting the contents on this list as well. In addition to just having the potentially inappropriate medications, it also lists situations with potentially inappropriate medications with disease states, so drug disease complications. The examples on here highlight central nervous system conditions and medications to avoid, a lot having to deal with those classes we previously discussed, including anticholinergics, benzodiazepines, and antipsychotics. The Beers list does identify 30 drugs to avoid in general, as well as 40 to use cautiously, along with those situational examples that we have as well. It also looks at drug-drug combinations that need to be avoided. And a lot of this, again, we come back to our CNS agents and trying to avoid opioids with benzodiazepines and gabapentinoids. More than 3 centrally nervous system active prescriptions. In addition to that, we also have some of our drugs that are used for UTI prevention or antibiotics, but some of the issues they can potentially cause as well here. And finally, with the Beers list, it also helps to address those metabolic changes that occur with aging, including kidney disease, as we see here, with recommendations based on renal function and drugs to avoid with chronic kidney disease. So it's a great list with lots of things to consider. In addition to the Beers list, we also have the stop-start protocol. This is some tools similar to the Beers list that were developed in Europe around identifying potentially inappropriate medications. And these are grouped by physiological symptoms and geriatric syndromes. STOP stands for the screening tool for older person prescriptions. So it's looking at identifying medications that can be discontinued. And the START stands for screening tools to alert doctors to the right treatment. So this is trying to avoid the start of potentially inappropriate medications. There is overlap between the stop-start criteria and the Beers list, but there's also some differences as well. Some of that might relate to the drugs available between Europe and the United States and some of our practices. However, studies have found that between both of these lists that the criteria are modestly predictive for adverse drug events, and that these criteria should be used in complementary fashion. Here's an example of start-stop criteria by system. Cardiovascular recommendations include keeping doses of digoxin to less than 125 micrograms, avoiding loop diuretics as first-line therapies, and CNS recommendations include issues with tricyclic medications due in large part, again, to their anticholinergic properties. Here's some of that data involving the start-stop protocol. Their studies found that half of hospitalized patients were on potentially inappropriate medications. By implementing the start-stop criteria, they were able to see a reduction in falls, reduction in drug costs, and most importantly, a reduction in adverse drug events, which improves quality and decreased costs of anywhere from 1/8 to 1/4. So a pretty good decrease there. So as I try and wrap things up here, we're running short on time. My apologies for maybe cutting into our Q&A time some here today. To summarize our presentation, when looking at polypharmacy, deprescribing, and medication management, it's important to consider what matters to the patient. We need to take their current status in mind, and again, some of that quality versus quantity decision is a discussion to have between the patient and their family and the provider. Along with what matters, we need to identify potentially unsafe medications, look for those opportunities to deprescribe, and use those tools that are available with us to help with our assessment and deprescribing, as well as activating our patients to improve their medication adherence. And finally, the age-friendly health system with the 4Ms framework provides a great framework within the clinical setting to address medication management and how medications are connected to those foundations of the 4 M's, including mobility, mentation, and what matters.